All right, so today we're going to talk about the future of health. It's a super broad topic. And so what I'm doing is, rather than even trying to provide an overview, I'm going to make 4 predictions, and I've got a short video to go with each one of those predictions. I've shared the link in the screen with this Notion page, so all this stuff is going to stay up. There's a challenge question at the end for those that want to think about something, kind of think about the future of health and how that would integrate with our lives. The video here will take about 20 minutes, and then we've got about 10 minutes for questions. All right, let's get started. All right, today we're going to talk about the future of health. It's such a broad topic that instead of even trying to provide an overview, what I'm going to do is make 4 predictions about the future, and then we'll walk through why I'm making those predictions. So the first of those 4 is that in the future, most of us will not go to the doctor's office. Why do we go to the doctor's office these days? It's a routine checkup. We're trying to prevent ourselves from getting sick. It's a thing that so many people talk about not looking forward to every year. We've known since the 1970s that these adult routine checkups actually don't provide any value. And there was a recent analysis in 2019 that looked across 17 studies and 250,000 people, showing that these routine visits to the doctor had no impact on cardiovascular disease mortality, cancer disease mortality, or overall mortality. So what should we be doing instead of the routine check, and what will we do in the future? Well, in the future, what we're going to want to do is a set of periodic tests that are personalized for your particular condition or morbidity or stage of life, that probably include some set of labs, some set of imaging, and probably some questions that will be asked to you through an app. And all of this can be easily arranged through an app on your phone. You can imagine getting a text message saying you can expect to have your labs drawn next week. A phlebotomist will come by your house, followed by a quick text message from the physician's assistant once they come back. And then, if necessary, a 15-minute conversation over the phone with some follow-up testing and even a diagnosis without actually going into the doctor's office. And you may not even talk to the doctor at all. So that's what I think it will look like in the future. Now the question is why? Why would we switch from this to this? To get at that, we have to think a little bit about how disease works. From the CDC's perspective, when you think about chronic disease, you're either susceptible to disease, you're sick, either subclinically, i.e. in the early stages of disease, or with clinical disease in the late stages. Or you have your post-disease, that is, you're disabled if you had a heart attack, for instance, or you've recovered and the disease is now gone. What we have found is that, so the clinical line is typically where doctors will pick up symptoms. If you go into the doctor's office, that's the earliest that it can be detected. And usually, by the time you go in with symptoms, you're back here. We've shown that doctors are no better at picking it up than people if they just go in with a complaint. What we want to do is we want to shift over here to detecting in the subclinical stage. The best way to do that is with laboratories and early imaging and with different tests that are sensitive and can pick up disease in its earlier stages. Hence why I think we're going to move to that model of basically having some set of tests that's drawn every 6 months, every year. And it will change with your stage of life, and it will change with the other issues that you're dealing with. Okay, so next prediction. All of your medical care will be personalized. And the main reason for this, we can see from genetics, actually. So this is what we're looking at here on the screen. Let me blow this up a bit. What we're looking at here on the screen is a list of all the human variants, all the changes in DNA for, let's say, a particular position. And they're rank ordered by the most frequent to the least frequent. What we find consistently across variants, across different genes, that over half of the variation in the human population occurs at less than 1% of frequency, which means, this won't be a surprise to most of us, but we're all different. And it also means that our medical care needs to be different if we're going to be successful. And that is everything from arranging diagnostic testing, like in the last point, to arranging treatments. And treatments are sort of the next thing that are changing. Almost all new clinical trials that are being conducted are conducted on a subset of the population rather than the whole population. And now I'm going to give you a quick intro. All right. So my second prediction is actually pretty related to my first prediction. And that is that all of your medical care will be personalized. For a couple of obvious reasons, we've seen a big push to do this in the last 5 to 10 years, actually, I guess 10 to 15 years at this point. Personalized care is better. It feels better for the individual. It also turns out to work better. And we're seeing that clinical trials are also moving in this direction of being designed around a select group of people, and then having interventions that are targeted for that group of people. So for both safety and efficacy, clinical trials are moving into the personalized direction. And I think everything you do, from the diagnostics and the regular checkup labs that you get to the particular treatment that you have, will be targeted somewhat based on your genetics, somewhat based on the sort of your general health state. And one of the main reasons for this is that if you think about human variation, this is an exponential. It's an exponential graph, and on the y-axis we have the frequency of a particular genetic mutation, or it's not. We call them mutations, but it's a particular genetic variant. And then on the x-axis, we have each individual variant. So and I've organized them by the most commonly occurring variant to the least commonly occurring variant. And what we find is more than 50% of the area under this curve occurs with variants that have less than 1% frequency. And what that means is that only about half of the genetic variation is common. Half of the genetic variation occurs at very low frequency. And what that means is physiologically, we are all actually quite different. And it's not surprising that we will need customized ways of treating each individual or groups of individuals based on this long tail of variation that occurs. So that's the main reason that all treatments will be customized. The way that a treatment looks now is, for instance, if you go into the doctor's office, they find that you have high blood pressure, they will typically put you on whatever the doctor thinks is the most relevant high blood pressure med based on large clinical trials and a couple of options that they choose. So right now it's sort of, you go to the doctor's office, you get a medication, you try it out. And then you update that medication if it doesn't work. In the future, what we're going to do is you won't be going into the office. As we discussed last time, you'll get a note that you have high blood pressure from your physician's assistant. On the last set of measurements that you did at home, they're going to be sending a genetic test to figure out what your specific variants are and which drug would be best suited for you. And there will still be some trial and error, But we've already found that, for instance, for blood pressure meds, they can reduce that churn by about 30 to 45%. So that's the way that we'll get medication, and all of your care will be assigned. All right. Now, the third prediction. Okay, my third prediction is that in the future, your insurance company will care about your health. How many people choose an insurance company based on how they think it's going to affect their health? Probably almost no one, right? Typically, it's based on how much is the monthly premium and how much can I be expected to pay in the worst case situation. So it's completely a financial decision. Different insurance companies have different groups of doctors. How they provide care is totally opaque to us. And insurance companies, by and large, also don't directly care about the health of their members, because unless they're payer-provider systems like Kaiser, they're mostly trying to just minimize their costs, and so they build massive administrative workforces that argue with doctors' offices. And what's shifting is we started with a fee-for-service model that was really put in place in the 60s by a couple of economists from Harvard. And this was the basic idea that physicians would get paid for time or for materials like procedures, etc. And what we saw and what we've seen with that model is the costs of healthcare have been steadily rising basically since the 1970s. In parallel with that rise, what we've seen are a growth in the number of admins in healthcare. And basically what's happened is the insurance side and the physician side just keep building these administrative armies that fight back and forth with each other on how much different procedures and different things cost and how much they should be paid. So a while ago, we started thinking about new systems. Obamacare first memorialized this in the Accountable Care Act. And Accountable Care has a different model that's currently accepted with, or that's currently being tried out in Medicare. Basically, the physician's office keeps a fixed amount of money based on the number of patients and their comorbid conditions. And the physician's office keeps the split between, let's say, for 2022, this is how much money they're paid, and this is how much their operational costs are. They get to keep the difference. So if they start providing care that either streamlines the care for particular conditions, or more likely reduces the number of conditions in the population or identifies them earlier, the difference between the amount that they're paid and the amount that they get to keep gets larger. And what we're going to see is over time, as this gets rolled out to a larger and larger fraction of our healthcare system, that there will be more focus on prevention, early detection, and health insurance companies will actually start offering directly to their members programs like the one I talked about, where they would do regular labs, imaging, questionnaires, etc., e.g. over an app via virtual care. Now, when you think about those early prevention and preventable deaths, the largest single fraction of preventable deaths, 40%, are attributed to behaviors. So there'll be a focus on a number of different things, but behaviors actually will get the largest share of that focus when we as we continue to switch to the accountable care model, and as there's more and more focus on early detection and prevention. And I can't wait for the day that my health insurance company sends me a note about a new periodic check program that they have that I could sign up for and get labs once every 3 to 6 months. All right. And then the final Okay, my final prediction is that in the future, doctors will pay more attention to your health than they do today. Today, mostly what they're checking when you go in to see them is, does this person have disease X or disease Y? Doctors do try to think holistically and come up with a global differential, but they're always approaching it from the perspective of minimizing disease or identifying disease and then treating it rather than maximizing health. In the future, that will change. Back in, I think this report came out already 10 to 12 years ago, there was a new taxonomy for disease proposed in the, I think it was by the American College of Physicians, that uses molecular biology and the underpinnings of physiology to understand. And that would be a sea change in terms of how we think about health. And I think in the future, it will be the basis on which physicians make their recommendations. There have been some systems that have been developed around this. So for instance, functional medicine very much tries to address this. And you're seeing a lot of modern talk about allostasis or inflammation, or a lot of David Sinclair's work talking about the survival circuit and the mechanisms around longevity. These are all physiological processes that make a big difference in terms of your overall health, and paying attention to those rather than individual diseases can be more effective in maintaining your health. And in the future, I think what we're going to see are treatment plans that, rather than giving you one medication for one disease, are going to be developed around certain physiological processes. So, in the same way that Levels has become the experts in metabolic health, you could see having a treatment regimen totally designed around your metabolic health. There would be another treatment regimen to improve your immune system, which can help reduce the impact of cancers, can impact cardiovascular disease and diabetes in ways we've already discussed. So in the future, I think what you're going to see is treatment plans that are developed to treat the underlying physiology and to really move you toward health rather than treat particular diseases. And that's going to have a huge impact in terms of what we can treat, how early we can detect things, and how we can actually prevent disease.
All right. So we'll move now down to the challenge question for anyone that wants to participate. Given these 4 changes, so number 1, we're not going to go to the doctor's office. 2, all of your treatment will be personalized. 3, your health insurance company will actually care if you're healthy. And 4, doctors will spend more time thinking about health rather than disease. What does that look like in your everyday life, right? What are the new things that are going to show up? And how will you think about your health when it's no longer a checkup? We can also just talk. Does anybody have any questions about this or thoughts?
I think, well, one of the things is I just think that we need some sort of representation of what our health is. That's not even well defined or holistically. Like, we each have our own internal idea of what healthy is, but I've talked about this at Levels in terms of making what I call an identity imprint or something. How do we reflect back to our members the state of their health and the kind of comprehensively what that means in a digestible manner, in a way that reflects their own mental model of what their healthiness means. And I think that's a mix of things like, some of the stuff around, I don't know, longevity, or will I be able to do the things I care about later on? Can I perform well now? What do I look my best, feel my best, all that kind of stuff. But there's no actual list of things that is a reflection of how someone is. So the world needs to come up with a model for that.
Yeah, well, and we need, I think, to your point, we need to start with a model of that. That's actually going to be, not to get into work too much here, but that's one of my big priorities for the next quarter, is actually developing a North Star health metric that consists of it'll probably start with a couple of lab values that are well correlated with health. already in the literature and in clinical practice. And then it's really defining health in terms of what people value, right? Because when you, I mean, it's easy to define, for a doctor to define a disease. It's much harder for us to define what health is, to your point. And I think it needs to be rooted in people's everyday activities. So for instance, some of the things that you'll see with folks in their 30s and 40s, when health starts to matter, they want more energy. They want more time with their kids. They want to be feeling better when they do that. They want better athletic performance. They feel like their knees are breaking down or whatever. For women, it's maintaining their fertility later. So I think you're absolutely right. And figuring out what, not only what are the metrics that correlate with healthy physiology, but what are the things that people are actually shooting for? That really determines what health is. And I think hopefully we'll spend some time both developing the metric, like identifying what the labs are and the underpinning science, but also talking with our members and figuring out what they really value in terms of health, and then we orient our service around that. And to your point, if this will take a while because medicine is still very physician oriented, but as doctors start to wake up to this, there will be much more personalization of what health means, I think. Absolutely. It's a great point.
Got a question, Taylor.
Yeah, go for it.
I was going to say, what do you think are the primary structural incentive changes that will lead to some of these for predictions? Because the incentives are lined up to kind of maintain the system as it is. And so barring any significant shakeup, what's going to push this in the right direction? Do you think there's a breaking point, or do you think it's just consumer demand?
Yeah, I mean, I think you're right. It's a massive system with a lot of entrenched interests. I touched on some of the things that I think are going to change it. So I think the biggest single thing that's going to change incentives is as we continue to push accountable care. Moving from a fee-for-service model to an accountable care model will ultimately make physicians and anyone who's making money in the healthcare system care about preventing disease. So that I think is the biggest, but will take a while. I mean, that involves state governments and Medicare and things like that. Another less expected influence that I think has already had a big impact is COVID. Because we have been forced to move from in-person to virtual visits, a lot of things have actually changed in the last couple of years. So as an example, you're seeing a lot of states now make coalitions to allow physicians to practice across state lines. And the reason during COVID was because states needed that, right? There was a shortage of physicians in certain states, but now it's going to enable doctors to practice virtually across the country. We've seen changes in reimbursement for virtual care that were pushed through by Medicare during COVID. And so I think, virtual care has gotten a big shot in the arm in the last couple of years, and that will also rocket things in the right direction. So I don't know where everything, you're right that there's more that's required to make these changes. But I think with those two and with several other things that are happening, I think we are moving in the right direction.
Taylor, I've got a question. Perhaps this is very obvious, but one thing that immediately struck me is that all of the changes that you discussed are currently sort of the pillars of the consumer health and wellness and health tech market. So remote personalization, focus on health and longevity. And I'm wondering, I guess maybe fundamentally, why is that? But part two is, are there blind spots of the consumer-driven movement or consumer health that simply just kind of following those trends aren't always indicative of where healthcare as an institution should go or will go? Does that make sense?
Oh, that's a great question. Yeah, certainly. I think every perspective has its limits. I think the consumer perspective has been, it's being forced on the healthcare system, right? Bit by bit, because this is what people want, and ultimately what people want determines what they get, even when incentives are misaligned. And I think these four, to your point, highlight some of the main consumer tenets. I think the issues aren't whether these things are valuable or not, or whether we should go there. The issue is how we should go there. So, for example, a few years ago, you started to see people put as reviews became super popular, and Yelp spread across the U.S. People started doing consumer reviews of doctors, right? And basically, all that does is give you a sense of the physician's bedside manner. It doesn't tell you how good they are. It doesn't tell you how likely they are to cure your disease. It just tells you like how many people like them. And I think if people start going to the doctor based on those reviews, you're not going to get better healthcare. So to me, it's less about whether these four things are valuable and more about how you implement them. For instance, if we go with a new taxonomy of disease moving toward health, if it's based on physiology and if it's connected to the sort of medical research complex, then that can be really valuable. If it's just as it is right now, based on kind of what people feel and wellness trends and things like that, you're not going to get the same level of traction because you can't actually prove you're making a difference in people's health. So I think it's not whether these things are valuable, it's how they end up being implemented that matters the most.
Thanks.
And I think Scott had a question too.
Yeah, I'm curious to know if you feel like there's maybe a step change on the horizon around the cost of getting labs done. I feel like there's been a couple of anecdotes in my personal life where I've had to make the trade-off of, I don't want to go spend another $400 to get this fancy lab work done. And I'm wondering if there's any headroom there for us or other people to make better progress where I'll give you one specific example because it's relevant to what we're doing. I took one of those paper tab blood tests and my LDL values came back quite low compared to what I'm used to, which is, I guess, good, but I also now trust neither of them. And so we were talking through like, well, you usually do the blood ones in a fasted state in the morning, and these are not fasted in the afternoon. And could that be impacting it? And they're consistently lower. It's not just like a one-off error. But because of cost, I was like, well, I guess I'll never know. And you just kind of keep going on with your life. And that's frustrating in a way that I feel like even the boring like lab work cost maybe has another order of magnitude to come down. So I'm hoping the answer is yes, but I'm wondering what your take is.
Yeah, I mean, we were already seeing this back in 2014, 2015. I think we saw it first with genetic testing because there was a lot of competition to make better machines and to make things more available. I think the speed with which the cost comes down is dependent on the demand, right? With genetics, there was a ton of demand for a long time, and so the cost came down very quickly because there was a lot of competition. We have seen a lot of competition in certain areas of the diagnostic space. I think in lab work in particular, there is a fair amount. It's not universal across all different tests. But I think for most of the common tests we would be thinking about, we should be able to get them for somewhere between $5 and $15 a test at scale. And what's being worked out right now is really more the collection and being able to get them to the lab. I think the next big frontier that needs to come down in cost is imaging. Imaging we've got these huge and really well annotated bodies of different types of MR, CT, X-rays, and we're starting to develop machine learning tools against them. What has not happened is the cost of running those tests hasn't come down yet because Medicare reimbursement has been so high for them. So I think that's the next area where I'm hopeful that there'll be more innovation. There are a few new companies that have started in the space, but it's still early. Matt.
Hey, Taylor. Question on how you think the consumerization of health, or putting the consumer in the middle of this journey versus really relying on the healthcare system, will change the trajectory of care and the predictions that you've made.
Sorry, can you say that again? I lost you there at the beginning.
What impact do you think the consumerization of health will have? Basically, the consumer at the center, making decisions and making, spending money and making purchases versus the healthcare system and the insurance system.
Yeah, I mean, well, to some extent, I think to Tom's point, there's going to be I don't know that there's always going to be tension between what doctors want and what patients want, because doctors ultimately and health insurance companies are controlling a fair amount of the spend. But by bringing consumers more into the middle, I think you're going to increase satisfaction in general, right? Because people will be able to choose what they want rather than what their doctor has recommended, and they'll have more visibility into it. I mean, today consumers have very little visibility into healthcare in general. So I think the bringing consumers into the center will make healthcare more palatable and a better experience for people. If it's done thoughtfully with clinicians on board, I think it will also result in better health outcomes. But that requires really a partnership that so far we haven't really seen. I think clinicians are still very entrenched, and we haven't seen. I mean, we're seeing a lot of new movement in health tech, and I think there are a lot of companies out there, but it's really physicians that need to open up to providing care based on what their patients want and doing joint decision making. I think that will ultimately improve health, if that makes sense.
Thanks.
Awesome. Well, I guess, and we are at time. Thank you guys. These were awesome questions. Happy to get any feedback you guys have, and sorry that it was, I was really just testing this out with these the multiple clips. So thanks for bearing with me through the talk, and good to see everybody.